Hello, my name is Brad Jones. I'm an orthopedic spine surgeon in Redding, California, and today we're going to be watching a single position surgery, and actually it's a multi-stage procedure. The patient is a 72-year-old gentleman. He presented with a device, interspinous device, placed by pain management that unfortunately likely was not the best choice for initial treatment. Regardless, he's got a dynamic spondy at 4.5 and a retrolisthesis at L3-4. So he's got significant neurogenic claudication, sciatica. We've been through the appropriate conservative care, injections. So the plan today is actually going to be a multi-step. The first process will be a posterior approach to remove the interspinous process device. Then we're going to reposition him for an ALIF. Unfortunately, I can't do an OLIF at this particular level at 4.5 due to the patient's anatomy. So we're going to do a straightforward ALIF followed by a reposition to a lateral position to allow for placement of the screws and a OLIF to complete the procedure.
So looking at this here, we'll show you through each one of the segments.
Yeah, and one very important aspect of the planning is the down screws, the right screws. We have to be mindful of the positioning of the patient relative to the table and make sure we're not coming at too much of a angle in terms of compromising the draping out of the position. So we actually want to medialize the screws, so we're coming at a little bit more of a perpendicular approach for the right-sided screws. So again, that's pretty spot on. The sagittal view, make sure no compromise there. And that looks good. And again, you can see we've medialized a little bit at the L4 level for the screw, again, to not only for the position, but also for rod placement in terms of if you're going to do perk placement of the rod. And again, looking at L5, he's got a pretty significant osteophyte on the right side at the L5 facet joint. So that's going to be a little bit of an issue with placement of the screw because, as Brittany had said earlier, we don't want to bury that screw too much and lose the polyaxial aspects of the screw. So we'll take a look at the sagittal views on these, and then we'll look at the rod itself. So as it sits right now, screws look great, good placement in terms of for the rod. The issue, if you can see on the far side of the screen right here, is especially on the right rod, which is the blue rod, there's a pretty significant lordotic bend. But if you note, this is the preoperative CT scan, and we have a pretty significant spondy that we're going to be doing an ALIF before we actually place the screw. So there's going to be a pretty significant, hopefully, correction of his deformity. So that's going to change a little bit in terms of the rod contour. And what Brittany's going to be able to do is once we acquire the x-rays, go from CT to fluoro, we're going to be able to probably tweak the screws a little bit, may shorten their length, but overall allow for a better contour of the rod. And then the other aspect that's very important is the actual skin where the towers are going to be going in. And especially on the right side, we want to make sure that we're not too far lateral, again, for screw placement.
So we go to full, show full CT and then show skin level. And we're taking this green line and drawing this out to about the skin surface, which we see right about here. Then going back into AP, control question mark will bring up these dots. Now we can see where that is going to be on the skin surface. And if we want to articulate these away from each other, so we see it looks like 4 and 5 are close to each other here. And we could bring potentially, and we see how that articulates the rod as well. So we want to make sure that we're keeping the rod straight, but getting these towers slightly away from each other.
Yeah, because otherwise they're going to be competing against each other, and when it comes time for the robotic arm to come in, there can be some issues with that. So pre-planning this part hopefully minimizes any of those issues. As far as the right side, I think we can medialize that some. Yeah. So you can see on the skin placement, the L3 trajectory was pretty far lateral. And again, that's something that we want to kind of make aware of before we start, so we can reposition that. So again, it's not an issue with the draping and access. And can we get an idea of like how far off we are in midline?
So we'll go to tools, ruler, and then measure off of the spinous process out here. So we're about
So about
5 to 6
about 6 centimeters off. And so one thing I'll kind of make a mental note is when we're positioning the patient, and we'll put a bump underneath the downside, and that typically will make the skin sort of bubble up a little bit. So we want to be mindful of that as well, but then even kind of guesstimate where 6 centimeters is going to be off of midline to make sure that we're got proper access. Because again, we can make some changes at that point with the screw placement to compensate for that. Yeah, no, I think that's great. Looks good. All right, so now we've accomplished the first part, which was the removal of the posterior interspinous. That's probably good right there, Danny. Interspinous device. And now Dr. Hatter has exposed 4-5. And so we verified that on x-ray. Everyone is in agreement. We got the psoas right there. Everything looks to be well retracted. So we got a pretty straight shot there. And I tend to go ahead and bovie a little bit on the cephalad and caudal end plates just to better define and also help with some of the smaller bleeders. So again, I just want to identify the borders. So when we make our incision into the disc space, we have a very good idea of where everything's going to kind of end up. Plus, sometimes I'm able to mark the midline. And we make our sharp cut. And I go fairly deep with this in order to fully release as much of the disc as possible. Again, be mindful of where all the vascular is and what's going on. And we can already kind of see we've got pretty good exposure for the OLIF up there at 3-4. So here we're just releasing as much of the disc as possible from the end plate. And hopefully get a lot of our work done with removing the disc. Even though this gentleman's 72, he's got fairly good amount of disc, although he did have vacuum disc on the CT scan. So we already got our pocket pretty much prepared. So pretty much any fusion I do these days, it's going to be a anterior column based, either through the OLIF approach or the ALIF combination. So the key thing is just making enough room for the graft, and then once that's accomplished, make sure we're far enough posterior so we can get a good sized footprint in. And just getting all that disc out so we can make sure we mobilize it and get a good reduction. And of course, also the other nice thing about the ALIF approach is you can get a central disc herniation in most cases, or even a lateral recess herniation. The whole thing I'm trying to prevent is not having to open up posteriorly. All right, I think that's going to be enough to at least get some trialing up, and then we'll finish up the end plates with a bone rasp once the trialing's done. I saved the bone rasping until the very end. Take a mallet, thanks. Yeah, I'm going to drop down footprint size. Oh, that's probably good on the table. X-ray? X-ray? All right, table back down a little bit. I'm going to try a 16. And X-ray? Yep, that'll be the ticket. All right, so we got a good reduction, good apposition to the end plates, fills it nicely. So I think that's a pretty good size. Final stage here for the prep. And if anything, when it comes to fusion, doing the carpentry work becomes very important. Make sure we got some good end plate bleeding. So there you can see Heather's putting everything together as one unit. So this is everything put together with the plate, and as well as obviously the inner body, and then the drill guide for all 4 screws. And there is going to be some adjustability in terms of moving the plate, cephalad and caudal, if needed, to get good alignment of the screws and basically where we want it. So at this point, it's pretty much ready to drop down, see what it looks like, and should have enough room, it looks like, for the guide and the plate. So table up a little bit, please. Kind of get it started there. Check around everything, looks good. All right, that's good right there. X-ray. All right, there we go. So you can see the graft in the middle. Shows up nicely. And again, make sure everything looks okay from a vascular standpoint. Make sure we're not squishing anything. All right. And final tap, X-ray. All right, I'm pretty pleased with that. So now it's just a matter of dropping all 4 screws through the awl first, through the drill guide. X-ray. Here we can check and see, make sure our trajectory of the screws are going to be okay. This will set it. X-ray. All right, so that's going to be pretty much our final position. And X-ray there. Good. X-ray. Good. X-ray. We'll keep going until we feel a little positive stop. And X-ray. All right, next. So I like to go one top, one bottom. That way we got everything locked. X-ray. And the other nice thing about this particular implant is you can also freehand your screws too if needed. Kind of depends upon the anatomy and the situation. X-ray. And X-ray. All right. And X-ray. All right, so last screw on top is going in. X-ray. Hopefully get the plate to lay down nice and flat. All right, so that should be it. All right, so now we're gonna remove everything. Should come out as one unit. We'll take a look in there, look at the locking plate. All right, so now we're gonna extract everything. And here we can see the drill guide and everything together. And we'll check all the sides and make sure we haven't dragged anything underneath there. But again, just a little X locks everything into place. All right, so pretty good reduction there from where we started. We've restored his sagittal height. That should fully decompress the spine indirectly. So I'm happy with that. All right, and table down. And now it's just a matter of getting the retractors out, closure, and then ready for single position. All right, so we're gonna be going to our lateral position. Key thing is we wanna go all the way over and position the backside right at the outer part of the table. That's gonna be the most important thing. So now we'll go ahead and do the axillary roll. 1, 2, 3. And again, what Sonny had said was having the axe roll, make sure we're not too far back towards the patient because that will end up distorting things. So now at this point, we want to do a waist bump. That basically supports the spine, puts it in a neutral position. Once we get him taped down, we'll get an AP and a lateral. Basically look at our alignment. Plus it gives us a little peek of what everything looks like implant-wise. So in terms of the waist support, kind of depends on how big the patient is, not just necessarily from a obesity standpoint, but the general frame will also dictate how thick the waist roll should be. And you want it right above the iliac crest. All right, so now we want the up leg to be as straight as possible, put some tension on the psoas. All right, so now just make sure shoulders and pelvis are going to be in alignment. All right, so now's the taping part. And you'll probably need about at least 4 rolls of 3-inch tape because it's going to be a tendency for the shoulders to want to roll forward. So I'm going to, for the chest part, actually go from my side to the posterior. Start with this, then we'll show you how we do the crest as well. So we're going to want to circumferentially go around the table, and you're going to want it on the skin. All right, check the shoulders. All right, one more pass. All right, so the next thing, feel kind of where the crest is. We got our ASIS here. Obviously, we have our posterior there. So this way, this gives me an idea of what's going on the posterior as well. I think we're going to have some pretty good, 6 centimeters off midline. So I think we're going to be very good there. So basically we want to go find the greater troch, and this is going to be kind of our landing part for the patient part down here. And that's going to give us access for our patient reference frame. And of note, a little bit unusual, but he's actually got a spinal cord stem that I actually failed to mention during the initial interview. So this is going to be potentially a little bit of an issue. I think we're going to be fine though, because there's the PSIS right there, and that's basically where the shank pin is going to go, and that's the support bracket here. So we want to make sure we have this area clear of tape and this area clear of tape. And the one thing, we'll get a AP and lateral film just to make sure that our overall alignment, that we're not torqued or tweaked at all. And then we got to stabilize the legs. So for this, typically, when I did a standard OLIF, you want to make sure your distal attachment or tape is below the knee. So basically, we're going to go posterior to the front and do another wrap, couple wraps, and that way holds this leg. Then we'll do another one coming up, and that way everything is secure. So now, you just want to come over this way. Basically, that's just going to secure the leg. We've got all of our points of fixation for our tape. And we'll just kind of over. Yeah, and then we'll wrap around just over here, Brian. All right, let's pass that around one more time. Just straight around. So at this point, we're going to bring C-arm in and get our initial pictures, see how everything looks. All right, so at this point, we're checking our overall alignment. I want to make sure we've got overlapping anatomy, so we'll get a true lateral here. There we go, spinous processes are better. All right, so you want to basically just get the spinous process in the middle of the pedicles. When I took out the vertiflex, pretty much eradicated the spinous processes down there at 4 and 5. So basically looking at the 3 up here, and that's actually pretty good. So I need to rotate his hips a little bit more posteriorly. And these are the little steps that you got to get right now. Otherwise, it's going to be an issue. So these are the little things that will make or break the case. So before you batten that down, come on in with the C-arm. Again, just make sure everything looks good there. All right, much happier with that. All right, we'll lock the shoulders down, head south if you can. All right, that looks good. So let's go up to a true lateral. All right. I think that's going to be fine. So again, we want to try to get as much material. This won't be too much of an issue with these things. And once we get the drapes on and the IO band, again, we're going to be kind of close here, but I think we're going to be okay with our trajectory. But here, I'm just basically, we can map out the crest, top of the crest. We have our ASIS here. And again, our window is going to be somewhere about right here for our patient frame, because we want that to be out of the way of our OLIF work when we're doing that. Top of the crest. And then here's, obviously, we've got our actual spinal cord stem right here. And we're going to be right under that guy. You can feel the posterior part right there. So I think our incision is going to be somewhere in that vicinity, maybe a little bit lower once we get in there. So it's probably going to need to be right here, actually. And you want that perpendicular to the patient as much as possible with the shank spin. Hopefully that's going to be enough real estate. All right, so now we'll just prep and drape, and I'll come back in and we'll kind of get everything hooked up.
Okay, so for mounting and lateral position, we want to have the bed frame adapter down closer to the patient's heels versus in a posterior where it is up behind their knees. And the purpose of this is because we're going to swing the arm fully out into the lateral position. And really important, what we see here, how they're doing is draping as inferiorly as possible there on that lateral side. It's going to be critical to our process with Mazor to ensure that we have the most exposure possible on that patient's right side.
All right, so now we're all the way draped out. And the first part I'm going to do is going to end up putting the patient reference frame. Again, you want to be in the basic zone off the anterior spine, about right there at the top of the crest. That's going to be the best way. And one technique you can do is if you have a obese patient and have trouble feeling the crest, you can actually get an 18 gauge needle and kind of palpate, make sure you've got the right trajectory. I can already feel crest on this gentleman. So another technique you don't necessarily need to have is the dilator with the cannula. You go straight to the actual pin itself. It's got a cruciform cross pattern. And again, this is the short one, correct?
Yes.
Okay. You want to make sure you don't have any tinting of the skin. Also don't want to make sure I don't get in the way of the robot to maximize that, but at the same time, not have a problem with OLIF. So I always like to get confirmation that we're going to be okay, and with our Mazor expert, Brittany, making sure that this looks to be in a decent position in terms of the robot. Now we're going to put in the Chance pin for the attachment. And again, you want this arm to be straight as possible. All right, that's probably good right there. So again, just get an idea of where my pin's going to go. And again, this is a point where if you needed to, you could actually put an 18 gauge needle through here to palpate the posterior crest to make sure you're going to be okay. But again, I want to make sure I'm outside of the battery pack here on this guy. So my initial thought of where it needs to be is hopefully pretty good. So again, you want to be perpendicular. And then I'm going to feel with the pin, make sure we can actually feel the crest. And you want this to be pretty well seated, close to the skin. You'll see there's a collar on it. All right, that feels pretty good. And again, making sure we're perpendicular. Good, nice, firm attachment. And at this point, we want to attach the Chance pin. So we might need to loosen up the robot a little bit to get that to fit. There we go. All right, now at this point, we want to make sure everything's as straight as possible. Yeah, let's get it, make sure we're good. Everything's locked now.
Yep.
And are we happy with the perpendicular part of the arm? Okay. And so one little trick here with the 3-defined scan is want to get all of our drapes as close to the body as possible. This basically is what keeps the robotic arm from getting too close to the patient. So this protects everything, gives you a little bit of a window of protection from the robot itself. All right, so now I'm just taking off everything here to expose what we got. And then we're going to move on to the next part of getting everything ready for the screws. All right, so make sure we get our positive click. There we go. So basically, this is going to be our accuracy check. There's a little dimple there. I like to do this before we mark our spots for the x-ray. There we go. Got to get it in. So again, you want to make sure that the distal tip is in the divot, and that means our accuracy is going to be good, which it is. So at this point, we want to define the cephalad portion of where we think our screws are going to end up going. And then our lower one, again, perpendicular to the spine. All right, so now we're going to move. We're going to do the oblique shot first. Go ahead and obtain our AP image. And we want the x-ray marker to be as close to the patient as possible without touching, obviously. All right, so this This will be for our oblique lateral image.
That's good. And then let's do a base image there.
I think that's going to do it.
Yeah, you have all your anatomy there.
So here's where we're going to start segmenting everything out.
We're choosing the clearest vertebral body. So as there's metal in these two, we'll go ahead and select for 3. The red reference dot is on the back of the body, base of the pedicle, and the sagittal, and then the AP, we have it right over the spinous process. It has already completed the segmentation process and now is registering each vertebral body independently.
So at this point, we're going to be working on the melding. And go from CT to fluoro, make sure everything overlaps. I personally look at the pedicles, and that looks good. So you can see the spinous process, everything is maintaining between the two different imaging. So again, nice thing about this is the vertebral bodies have changed position. There's hardware gone, there's hardware in, and Mazor X is still able to differentiate that, and everything overlaps perfect. That looks good. So the other part we'll do at this point is see how our plan looks relative to what we see for the L4 readjustment.
So that would be the updated CT by fluoro
Okay.
right here. Are you okay with
Yeah,
that
I think
curvature?
that looks
It
good.
looks
Yeah,
pretty
looks
perfect.
good. Yeah. And if we need to do some slight adjustments once we get all the screws in, we can do that. Perfect. All right, Olga, thank you. And so we will, once I get the OLIF in, I typically want to get a X-ray as well without the reference frame on. So now at this point, what I typically do is sort of map out where on this particular portion the right screws are going to go, so I can get an idea, is our trajectory going to be adequate, and looks, we're going to have so much room, it's good. So at this point, I put the cannula in. So here it just gives me an idea of what kind of incision. I want to make sure I'm not fighting any of the tissue. And again, we're going to have some overlap there a little bit. So the skin incision will be one long, basically a Wiltsy incision, and then perk through the fascia. We know that with our 5 screw here, it's going to end up wanting to be, once we get it placed here, so our incision needs to be at least long enough to accommodate the repositioning of the towers. So we get everything lined up, and try to do my best to split the difference. All right, so again, just want to mobilize the tissue down to the fascia. And keep in mind that your angle of where you're going with your screw placement, so you're going to be heading uphill to a degree. And when we start putting the screws in, I always want to go from the cephalad to the caudal screw, keep our navigation a little bit more in line. So with this, we're just basically going all the way down to I feel bone. You want to turn it cephalad and caudal, and this is clearing our soft tissue. All right, and initially I will put it down on bone, but importantly, you want to make sure that before you start drilling, you actually pull it back approximately 10 millimeters or so. It has a positive stop. And because we're using 7.5 screws, we're going to end up tapping as well. Okay, make sure nothing slides out. Check everything on, it looks perfect. And again, it's a 30 millimeter drill for the Midas. And for this, I just want to make sure that I get through the pedicle. Once I'm into the body, I'm not worried about it. So again, nice and following our plan. So that should be enough for that. And we'll back it out and be ready to drop a screw. If I'm using just 6-5 screws, we definitely don't tap, and depending upon the bone quality, very sclerotic bone, you need a tap. So again, you want to make sure you look at the soft tissue, make sure that you're not drilling through the cord. Good. It's all light touch at this point. You don't want to muscle anything at all. And there you can feel a positive bone. With the tap, we've already got the distal tip of the screw where we need it. It's just a matter of watching. Go slow. Make sure that everything's picking up. And I typically will leave maybe just a little proud, not always down exactly to the plan. This way I know I've got enough polyaxial movement. All right, and one down. So I also do at this point neuromonitoring basically for any EMG. With the ALIF and the OLIF, I do completely relax the patient, makes the maneuvering of the tissue much easier, especially the muscles, obviously. Okay, let's go ahead and move it down. So here I'm basically making sure that the end effector does not interfere or hit our screw tower. There you go. And we've got plenty of room. There's not any tension on it. So again, just repeat the process. All the hard work has kind of already been done at this point with all the registration, the acquiring the images, the plan. Now it's just basically letting the system do what it's intended to do. All right, that's good. And the one thing you want to make sure you do again is just come off 10 millimeters, hold the cannula, and then just advance the midas, keep an eye on what's going on. And then the other thing too is if you let go of the cannula, you'll end up potentially losing it because it's going to have gravity working. Again, just make sure. And at 5, this is really where the tap is going to come into play. So again, I just want to make sure I'm through the pedicle. Check the navigation, that's good. And again, just a slow advancement. Light trigger. So there we go. Once I let go a little bit, you'll see things line up as they should. So got 2 down. So this is the reason why the drill is going to be nice. We're actually going through a fairly raised portion and through the facets like we did at 4. So again, down on bone, everything's in alignment, 10 millimeters off. That's definitely sclerotic bone. You can see on the sagittal view how sclerotic that pedicle is. So this is where the tapping absolutely is important. So definitely tight at this point. You want to be mindful you're not torquing the arm too much. And sometimes if it's very sclerotic bone, I'll actually put it in by hand rather than power ease. You can see there, it will fight you a little bit. There we go. That should be good. And that's the downside, right side. So now we'll do the same thing on the top. Looks good. We're on bone there. Come back a little bit. And just straightforward. There we go. Spot on. Just want to get past the pedicle. Good. All right. So we're going to be riding on top of the tower a bit. So I just want to make sure that doesn't push us. Definitely some sclerotic bone. Again, we're falling back in the starting hole. Definitely sclerotic. And I'll put the tower heads on once I get this kind of adjusted to where I want it. All right, perfect. All right. Yeah, that was down pretty good. And we got some leeway here in terms of where the screw was relative to making it a little bit easier to pass the rod. Again, I'll do the same thing at 3. So we'll transition all the instruments and stuff to the OLIF part at this point. So here what I'm doing is, and what Brittany was able to do is basically from a level marking standpoint, again, the CT scan was obtained pre-operatively, and obviously there's no pedicle screws in there, no ALIF gauge, and because of the segmentation, Brittany can show us the 4 screw, and so I know I'm up at 3-4 at that point. And again, we see on the right-hand side of the screen is going to be our coronal view, and obviously we've got the axial view on the left, and basically just trying to get my trajectory of where we need to be, where the disc space is relative to patient's anatomy. So again, I always mark the disc space on the posterior margin as well as on the anterior. If you're gonna, so for a 2-level, I'll end up making my incision up and down. But if I'm doing a 1-level, basically I know this is the posterior anterior margin of the disc space. I'm going to be coming in at a oblique angle, and I want to make sure I've got enough room to come up to a 90 degree. So I will tend to split the difference, go a little bit more posterior midline, and then just obviously a little bit more anterior to the front part of the disc. And that's going to be basically our incision. Start our approach. So again, once we get down to the external and internal obliques and then the transversalis muscles, we go in line with the fibers. All right, so now we can see our fibers here. You want to go in line with the fibers. Just kind of split in the middle. So again, at this point, it's just standard OLIF. Only big difference is we're using the navigation, obviously, off the Mazor X platform. There we go. Reposition those Gelfies to get those 2 layers back. And be mindful of the patient array that you don't hit it. That's why I got Brian there to keep me honest. And also keeping in mind that we've done an anterior approach on this guy, so you can see the neurovascular bundle there, so we want to make sure we stay clear of that. So we'll pick a direction for that to go. And when I first started doing OLIF, everything was done basically blindly, in a sense, with just finger palpation and placement of the guide. And then with relaxation, direct visualization, it's actually probably a better technique to allow mobilization of the front part of the psoas if you need it. And there we can see peritoneal fat. So at this point, we're through. And now just kind of feel the anterior border of the psoas. Sweep everything anteriorly. Make sure we're in their plane. So again, this is just finger palpation. Remember that we did do an ALIF, so there's likely going to be some oozing going on baseline. And once I know where the psoas is, at this point, try to get a better idea of my level, what am I looking at, what level's in front of it. So I usually use the guide wire 1. And this allows me a little bit longer than the chicken foot. All right, so we're going to go cephalad a little bit. All right, there's 4 there, so that's going to be our disc space. A little bit of bone spur, that's going to be our outer annulus there. I'll kind of mobilize the psoas. Again, he's got a pretty good sized psoas. That's fairly anterior on the vertebral body. So you can use the retractors also to your advantage for some soft tissue. So it's going to be some resistance, but just go ahead and push down on it. Keep your toe like that. So again, what I found over the OLIFs I've done, that relaxation makes a big difference in terms of your approach and the ease of mobilizing, because the obliques will really tighten down quite a bit. And here we're just mobilizing the psoas. Again, we're going to expose enough to get our annulotomy done correctly. All right, so at this point, I like that. We're down on the annulus. We're in line with the disc. Go ahead and put the guide wire in. All right. Okay, so looks good. I'm happy with that. All right, so now we'll put in our measurement for the retractors. You know, I want to make sure I've got everything swept out of the way. Go down, dock on the bone. And here I'm just going to verify that we are indeed where we need to be. All right, that looks good. And then scan down to make sure we see the 4 screw there. So now we know that that's going to be pedicle of 4 there, and that's going to be our 3/4 disc there. So we're good level-wise. So anterior blade will help get that retroperitoneal fat hopefully out of the way, and then we'll work on that psoas to make sure we've got that adequately out of the way. Nice thing about this is, there you go, you can toe it in. It really pulls everything anteriorly. So we can see at the top of the retractor, that's going to be our psoas. So ideally, I'd like that behind the retractor. So before we pull the guide wire out, I'm going to see if we can just mobilize that and then sweep the retractor back. So I'll actually take the anterior blade out and make sure we can pull that out of the way, because the other issue too is otherwise your plate's going to get laying on top of that, so we don't want that. Just trying to sweep that up and around the retractor. So here, just basically again want to verify our posterior margin of the disc. Good. So we're going to be able to go back a little bit more, and our trajectory is going to be good there. So where the guide wire is going to be sort of the anterior part of our annulotomy. I'm not going to want to go any further than that. Again, we've got plenty of real estate back there for our annulotomy. So I usually take the annulotomy window out, and then we'll take a pituitary, clean out some stuff, and then take the cob to release the cephalad and caudal margins. Good disc coming out. And again, much like at 4 or 5, he had a little bit of a vacuum disc issue here, so I don't expect a heck of a lot of disc, but you know what we got. All right. So you should start with the cephalad end plate. Make sure we're good there. This also helps clear the cartilaginous end plate, and we're just going by feel at this point. Feel the end plate. All right, he's collapsed down on that side quite a bit, so you may end up using a dilator potentially. All right. Rotate this around. This way you've got your cutting edge of the cob where it needs to go. Right off the end plate of 4. Verify everything. Come up to the 90. All right, mallet. There we go. Yeah, make sure you release that contralateral. So what this is going to do is just basically opens up the lateral side. All right, probably jump up to like a 8. Yeah, see what that feels like. get our 90 degrees. That's good. All right. So at this point, I don't necessarily use the navigation for this. You can. You're looking directly at it, so you kind of know your angle, you know what you're doing. Trial here, 8 millimeters, 45 millimeters in length, and they're all in 6-degree for the trial. There we go. All right, so there we see our implant. Go ahead and advance this in, do our turn to the 90. It just falls right into the space. It's nice. So now we can gauge, is a 45 really going to be enough length? We'll end up pulling the hand a little bit more posteriorly. Probably going to want a 50 when it comes to it. And we have a 50 trial. I can't. Okay. All right. So let's do a 50 length, and I'll jump up. Yeah, I'll just do a 10. We'll gently go up. So at this point, you basically go off of feel of how the implant feels, and typically I try not to over distract and be mindful of how the plate situation is going to be. So we'll probably go up to a 12, and that'll be our last one. So I don't know if you guys noticed when I was pounding in the 12, it was bouncing back. So that basically means we know we're released on the contralateral side, but again, a little bit more release on towards the posterior on the annulus. That should hopefully improve that situation. And you can always stick a knife in there as well and release back if needed. There we go. All right, we'll definitely want a 1250. So at this point, we're pretty much done with the navigation portion. We've got our level confirmed. So everything else at this point is just kind of muscle memory to be able to put the implant in, turn to go orthogonally at the right time when you get the implant nose in there. So here the plate, when it gets attached, will be in alignment with the actual graft, and then once I get it to a certain point, we'll loosen it up and I'll rotate it 90 degrees so we have a cephalad caudal plate attachment for the screws. So there you go. So again, much like with the ALIF, we've got a drill guide here, which are in alignment with obviously our entry points. This is the device, it's a X cross tube, and once we get to a certain point, you'll see where I loosen this up here. It allows me to rotate it, and then we'll impact it all the way down till we feel good bone-on-bone apposition. And then I always like to get x-rays at this point because we want to verify everything at that before we commit to the whole 9 yards. So you can feel the nose going in at that point. Go a little bit further. Drop it down. We'll look inside, see where we're at. So at this point, we're down. I'll rotate the plate. And once we rotate it, you can see there, it's got some leeway, anterior and posterior. So I definitely want to make sure we're more on the kind of middle part. It doesn't have the biggest vertebral bodies, but hopefully you can see that right there. So at this point, we'll lock the plate relative to the graft, do some final impactions, make sure we're down. Look in there. All right, so you can see the plate's on bone on 4. We're down on 3. So now there's an inner plunger, which will open up the channels. And again, as we come anterior, screws are going to be going more posterior because of our angle. Keep that in mind. I typically use 25 screws regardless of plate. I just want cortical fixation more than anything. Here we verify that our screws are down, captured in the plate. Got a locking mechanism, simple twist. Here's our anterior portion of the plate. So at this point, I'm going to leave everything in while we get x-rays in case I need to make some adjustments. All right, so we see the anterior plate, got our OLIF plate, that looks good. Can't tell if we're above or below the screw at this point from this distance, but we're going to go ahead and switch to a cross table. Yeah, so we end up, looks like the screw went above, which is fine. We still have purchase there, so that's good. And here you can see also the trajectory of the screws are all spot on. You can see the medial border of the pedicles. That looks good. I'll take that out, and then we'll take some measurements for our rod. All right, so I'll take a 70 perk rod. And I'll go ahead, always get the measurements for both rods. That way, hand stuff back to Heather and less tools to fuss about. Again, not unusual to have some difference in the rod's length, so probably gonna do a 70 on that side just to have a little bit of safety factor. Yeah, 270s. So I'm gonna go ahead and do the right side rod first. So go down, I wanna feel the screw. I'm already through there at 4. Hopefully, let's see if we got lucky and got 5 too. Make sure we're not tenting anything up here. That feels good. With our set screws, we'll see. That's close. All right, and I got a ratcheting driver here, which will help. I usually go in the middle first. And that black line there, we want to get all the way down. So I usually keep the rod holder in there, at least get the preliminary tightening done on the set screws. All right, so now I'll take the holder off at this point. We'll do our final tightening. So again, I always start in the center and work my way out. So at this point, I'll go ahead and I'm gonna pop them out now, get that out of the way. So we'll pop the reusable towers out. And I usually check to make sure I'm not tenting anything on the fascia, muscle, and that feels good. All right, so we'll do the same thing up here. All right, very happy with how that went. That's it, we're done. Brian's gonna close up everything.